Welcome, everyone, and thank you for joining us for the third session of the Leveraging Midwifery-Led Care to Address Disparities in Equity in Medicaid Virtual Learning Series. I'm Jennifer Moore and serve as the Founding Executive Director at the Institute for Medicaid Innovation. Before we begin today's session, we would like to thank our funder, the Yellow Chair Foundation, for their commitment to advancing important maternal health topics, especially in Medicaid. Through their generous and ongoing support, we are able to offer this free virtual learning series. This learning series brings together Medicaid stakeholders, including state Medicaid agencies, health plans, and provider groups. With over 300 participants joining the learning series opportunity, we have representatives from 44 states, the District of Columbia, and the federal government coming together with the shared goal of increasing awareness of midwifery-led care by applying key findings from IMI's landmark report to their national, state, market, or local clinical setting. When registering for this learning series, participants overwhelmingly selected improve understanding of the impact, role, and value of midwifery-led care in the Medicaid population, particularly as it relates to addressing disparities and improving equity as their primary learning objective. Today's session directly addresses this objective as we begin to explore the key elements related to the regulatory environment for midwifery-led care. During today's session, the speakers will provide information relevant to three main learning objectives that build upon the required activities that you completed before this session. They include, first, identifying variation in state regulatory requirements governing midwifery-led models of care, including licensure, scope of practice, credentialing, and contracting. Two, identifying Medicaid credentialing and contracting requirements for freestanding birth centers. And third, identifying freestanding birth center accreditation options. Before we get started, though, with our panel discussion, my colleague, Chloe Bax, will review a few housekeeping items.
Good afternoon, everyone, and welcome to session 3. As Jennifer said, I'm going to review a few details for today's session, along with a few reminders. For today's session, this will be recorded and it will be archived on the IMI website. Except for all panelists, all lines will automatically be placed on mute. During the meeting, the chat feature will be disabled for all participants. We have reserved 15 minutes at the end of the panel for you to ask questions of our guest panelists. To participate in the discussion with the speakers, please use the Q&A feature to submit your questions and comments. Please feel free to submit questions throughout the session. The questions will be consolidated and shared by the moderator during the Q&A portion of the panel. At the completion of the session, you will receive an email message with a link to complete a short 5-minute evaluation survey. As a reminder, completion of the evaluation is mandatory as part of your participation in the learning series. We actively review and incorporate your feedback into our future sessions. We look forward to hearing your thoughts about today's session. Finally, all materials will be made available to you on the IMI and CHCS websites about 2 weeks after the presentation date.
Thank you, Chloe. Now let's get started with today's session. I am delighted to introduce our session moderator, Dr. Kane Lowe, who will help us set the stage for our panel discussion. Dr. Kane Lowe is a past president of the American College of Nurse Midwives and holds the position of Associate Dean of Clinical and Professional Graduate Studies in the School of Nursing, and is also a professor in the Department of Women's and Gender Studies and Department of Obstetrics and Gynecology at the University of Michigan. She is also in full scope midwifery practice at the University of Michigan Health System, Michigan Medicine. As a leader in promoting evidence-based practice during childbirth, Dr. Kane Lowe is one of the co-authors of the National Alliance in Improving Maternal Health Hemorrhage Bundle and the Reducing Primary Cesarean Bundle. She also has led the American College of Nurse Midwives Reducing Primary Cesarean Project and is a co-director of the Blue Cross Blue Shield Obstetrics Initiative focused on reducing primary cesarean throughout the state of Michigan. We are excited to have her here today to lead our discussion. Dr. Kane Lowe, I'm handing it off to you.
Thank you, Jennifer. It's my privilege to be a part of this esteemed panel today, and I really look forward to our conversation. In order to set the stage and to make sure we're all on the same page with some general understanding, I'm going to be providing sort of a 30,000-foot overview of the U.S. maternity workforce and focus on opportunities to increase access to quality maternity and reproductive health care. Next slide. I'm going to be having this conversation with you in the context of understanding that many of us would describe our maternity care system today as broken. We in the United States, which spends the highest per capita on maternity care services in the world, has one of the most deplorable maternity mortality rates in this country that's been rising instead of declining, similar to other countries that would be in our resource category. Furthermore, we have health inequities where African American women are 3 to 4 times more likely to die of pregnancy complications than white women. So we have deplorable statistics and racism inherent in our system that results in health disparities. Next slide. In this context, when we look at where we have providers of maternity care services, and we look particularly at the role of certified nurse midwives per 1,000 population, the takeaway from this slide is really just to highlight the many spaces and areas where there is no access to a certified nurse midwife as a source of maternity care within this country. In fact, out of more than 3,000 counties in the US, 56% have no access to a nurse midwife in that area. Next slide. When we compare that to the access to obstetrician gynecologists as resources for maternity care services, we again see broad areas of the country without services available. And in fact, 46% of the counties across the United States have no OBGYN provider in their area. And when we look at the next slide, what we see is that when you overlay the two, almost 40% of the counties have no access to a midwife or OBGYN provider that they can access for their maternity health care services. So we have what has often been referred to as maternity care deserts. Furthermore, the location of many of these areas that don't have services align with being rural or having long distances between where they could access a provider of care or a site for services. Next slide. So taken together, what we see is an opportunity to expand access to midwifery care. For my comments today, I'm going to focus on initially Amcb certified midwives, which are midwives certified through the American Midwifery Certification Board. They carry the credential of certified nurse midwife or certified midwife. Certified nurse midwives have national certification, as I noted, from Amcb. They have completed graduate education, including a master's or doctor of nursing practice degree. They attend a nationally accredited education program, and nurse midwives are able to practice in all 50 states. Most of their clinical education occurs predominantly in the hospital setting, but it may also include community birth experiences, including experiences in birth centers and in homes. The workforce generally is around 13,000 individuals who are certified as nurse midwives in the US. In addition, another Amcb certified midwife credential does not require nursing, but does complete graduate level education in nationally accredited programs, similar to the programs that are accredited for CNMs. CMs take the same certification exam as those who become certified nurse midwives, and they're often educated side by side with certified nurse midwives in schools of nursing, but also in schools of public health and other schools. The challenge for the CM credential, which is newer, is that they're only able to currently practice and be recognized in 6 states, and they have a workforce of just over 100. So this is a growing area, an opportunity in the workforce to have certified midwives joining in with certified nurse midwives together with the same overarching credentials, but still needing to work through individual state recognition for the CM credential. Next slide. This is just an infographic to show you that the midwives that are certified through Amcb are also members of the American College of Nurse Midwives if they choose to be so. They're represented by the American College of Nurse Midwives, and this just demonstrates the similarity in that they have a bachelor's degree. The CNM, usually that is in nursing, the CM not in nursing, They both get graduate degrees through accredited programs, complete a nationally qualifying examination that's the same, and then they pursue state licensure, which is where we see our variation in difference, simply because not all states recognize the newer certified midwife credential. These are then clinicians, researchers, educators, and providers of primary healthcare services. Next slide. The scope of practice for the midwife who's credentialed as a CNM or CM includes a full range of primary healthcare services for women from adolescence beyond menopause. The services include independent provision of primary care, gynecologic and family planning services, preconception care, care during pregnancy, childbirth, and the postpartum period, including care of the normal newborn for the first 28 days of life, and treatment of partners for sexually transmitted infections. Midwives provide initial and ongoing comprehensive assessment, diagnosis, and treatment. They also include care that encompasses health promotion, disease prevention, and individualized wellness education. They provide this care and service in partnership with families in diverse settings such as ambulatory care clinics, private offices, community and public health systems, homes, hospitals, and birth centers. Next slide. I would be remiss if I didn't also address that there are additional midwifery credentials in the United States. And while the focus from the IMI series has been on the role of certified nurse midwives and certified midwives within the Medicaid system, there are also certified professional midwives who are recognized for Medicaid reimbursement in select states. CPMs have national certification from the North American Registry of Midwives. They have varied pathways for the completion of post-secondary education, and they may be in degree programs or complete individual portfolio options for educational assessment to meet criteria for their certification. CPMs are able to practice in 34 states and represent a workforce of over about 3,000 people. Their education occurs in a variety of clinical communities, but it's a community-based clinical experience predominantly in homes and birth center settings. Some states also offer different credentials for direct entry midwifery pathways that may be unique to their state. The site of care for midwives that have unique state recognition is predominantly in the home birth or birth center setting. Next slide. This is just a quick reference to let you know that there is also variation across state settings in terms of the practice environments and the scope of practice that's able to be provided. Across the United States, while the credential may be similar, the recognition and full scope practice authority in each state does have some variation. The most restrictive states, which are recognized in the hybrid model, or where the red states are areas where there's requirement for supervision of the midwife for practice. The rest of the country recognizes either collaborative agreements, which are indicated in yellow, or they have independent practice where the collaborative agreement and relationship with a physician is not required for their practice. There's recently been changes, as you'll note, this just was updated, where California removed the restrictive supervision requirement for practice, and we anticipate this trend will continue. Next slide. While this slide doesn't represent the recent change in California, what this does is overlays where births are attended by certified nurse midwives, the scope of practice that's available, and what you'll rapidly take away is that when you have states with full practice authority, you also tend to see higher rates of birth, so that what we can align is that if a state recognizes the education, training, and full scope practice ability of the midwife in that state, they're more likely to practice there and to be available for the constituency within that state. Next slide. I'm just going to highlight that we have a practice agreement with the American College of Obstetrician Gynecologists that supports the role of certified nurse midwives and certified midwives. Next slide. And while I'm not going to read all the way through this, what I want to highlight is that ACOG, the American College of Obstetrician Gynecologists, and ACNM, the American College of Nurse Midwives, has a collaborative relationship that supports the independent expertise they each have and encourages practice to the full extent of the education and training of each of them as independent clinicians, and encourages collaboration based on the care needs of the patients they're serving. Next slide. ACOG and ACNM also strongly encourage a redistribution and support for further education and training to increase the maternity care workforce. And they look at the value of having options available so that when individuals are seeking maternity care services, they should be able to have access to the right provider at the right time in the right place. Next slide. We see a number of educational programs available for midwives throughout the United States, and the formats that those education programs take varies. But what we would note is that while the number has remained relatively stagnant, the number of graduates, next slide, you will see is really growing. We are seeing more and more students entering the profession and more being able to be available as new certified providers. Next slide. So much so that we're seeing a rise in the number of midwifery graduates, while the number of OBGYN providers has remained relatively flat. So our opportunities to address the shortage areas is to really try to turn around this number and expand our midwifery graduates so that they can be placed in the communities that need them. Next slide. The number of midwife-attended births has greater opportunity to grow. And what you see from this slide is that midwives, while they are only currently attending approximately 10% of all births, the opportunity with growth in the workforce is to attend an even greater population. Next slide. So that what we will end up with is a right distribution where midwife-led care, collaborative care, and physician-led care can be right-sized to serve the population needs. So that what we end up with is the right provider in the right place at the right time. Next slide. One more. And this couldn't be more accentuated in terms of the needing to address having available services and resources at this time than with COVID. It's exposed the health disparities and also raised greater questions about what is the right site for birth and who is the right provider for care. So I'm going to be turning us over to our panel. Next slide. Well, we'll be able to talk about how we can think about these complex issues of right place, right time, and access to many different services that would be available for the communities that we serve. So to explore these issues in greater depth, I'm pleased to introduce our esteemed panel. Our first panelist is Jill Allman. As a birth center midwife in rural Texas, Tennessee for 26 years, Jill worked to improve access to care in some of the most underserved areas of Tennessee. She serves as a faculty member at Frontier Nursing University in a nurse midwifery education program and is past president of the American Association of Birth Centers and currently serves as chair of the AABC Government Affairs Committee. We also have Karen Dale. Karen is the market president for AmeriHealth Caritas District of Columbia, a mission-based Medicaid managed care organization in Washington, D.C., and the Chief Diversity, Equity, and Inclusion Officer of the AmeriHealth Caritas family of companies. Her focus includes applying a health equity lens to impact all levels of policies, processes, decisions, laws, and outcomes to the communities that she serves. She also leads a decidedly metric-driven business approach to mobilize leaders and accelerate strategies to advance diversity, equity, and inclusion inside and outside the walls of AmeriHealth Caritas. And finally, we have Melanie Reese. Melanie Reese is the policy and subject matter expert for women's health, family planning, and maternity health services for the Colorado Department of Healthcare Policy and Financing. Melanie has focused her efforts on policies targeting decreasing unintended pregnancies, teen pregnancy prevention strategies, and methods to support appropriate women's health and maternity care services. Each of you represents a different perspective when it comes to licensure, credentialing, and contracting regarding midwifery-led models in Medicaid, including Medicaid agency, Medicaid health plans, and credentialing for birth centers and the national regulatory landscape. Reflecting on your experience, I'd like you to describe where you have been seeing success in implementing midwifery-led care in Medicaid populations to support birth equity, and where you see the opportunities for continued growth. Dr. Reese, would you mind kicking us off? Dr. Reese, I think you're on mute. While you're working on your mute, why don't we pivot to Ms. Dale?
Sure. So in my experience, the success has been limited. Where I've seen success in the district is where we've had a freestanding birth center, have midwives, and there's been good promotion to our members about the availability and the accessibility. What that opens up for us, though, is to focus on how we leverage what is possible with what we achieve. And some of the opportunities to do that include recruiting more nurse midwives and making sure that payment and promotion of their services is one of the first choices. What we have is a much more, and it was well demonstrated in the slides that we just saw in the overview, that the preponderance of care is aligned with someone being high risk, even though many of our moms are not high risk. So it's doing that proper education and promotion of the midwives that we have. I'll give you an example that really aligns nicely with the slides, which is we have as a plan over a 3-year period about 7,200 births, and only 10% of those are midwife attended, and less than 1% were midwife attended in a freestanding birth center. So a lot of work to do in terms of how we improve and leverage what we know works and educate women about their choices.
Thank you.
I think I'm off mute, if that works.
Yes, Dr. Reese, thank you.
First, I wanted to thank everybody and say good afternoon. Thanks for inviting me to participate in these important conversations, and thank you everyone for joining us. I also wanted to make a couple of general comments about Medicaid services in general before I talk about Health First Colorado, our Colorado Medicaid program. I just wanted to know and to state that every state has a lot of flexibility when they create their own system and method for service provision. Each state can differ in who provides a service, where that service is provided, which services are actually covered by Medicaid, who specifically can be paid for a service, and how much each provider type is paid. So when I talk about Colorado's success as an opportunity for continued growth, you know, it's good to know that Colorado isn't a huge populated state. We only have 5.8 million, but about a quarter of all those individuals are covered by Medicaid. We have been very lucky to have certified nurse midwives as an eligible provider type for many years, and we support them in multiple ways. In last year, in 2019, we had over 62,000 deliveries. More than 37% of all those deliveries were actually covered by Medicaid. Certified nurse midwives attended to about 17% of all of our deliveries in Colorado, and they attended about 22% of all the Medicaid deliveries, associated deliveries. In 2014, Colorado received federal approval to enroll freestanding birth centers as a unique provider type. The licensing and oversight for freestanding birth centers, like most of our healthcare facilities, are regulated by my sister agency, the Colorado Department of Public Health and Environment. We had about 800 plus deliveries in freestanding birth centers in Colorado in 2018. That's about 1.3% of all the deliveries. And the certified nurse midwives attended about 94% of those Colorado deliveries in freestanding birth centers. For the Medicaid deliveries at freestanding birth centers, nurse midwives attended about 88%. So when I look at some opportunities for continued growth, even though we have enrolled and increased our numbers of nurse midwives over the last several years, we still have quite a few challenges. Colorado is organized in 64 states and about 2/3 of, or I'm sorry, 64 counties. About 2/3 of all of those counties actually are rural or considered frontier counties. And I don't know, I learned this too. Frontier counties are defined as less than 6 people per square mile. So we have a challenge in having access to nurse midwives in about a third of our counties. Only 2 of the 23 frontier counties listed nurse midwives as being available and enrolled to access care. Primarily, our nurse midwives are enrolled and located in our urban areas. We also have some challenges with our freestanding birth centers. We have very low numbers that are actually licensed in Colorado, and even a smaller number of freestanding birth centers have chosen to enroll as Medicaid providers. So that's also a challenge. Additionally, all of our freestanding birth centers are located in urban areas. So these are some of our major concerns and challenges as we move forward, how to make sure we have these wonderful provider types accessible to all our Colorado members. And I'll turn it back to Dr. Kane Lowe.
Thank you. Dr. Allman, would you like to speak to the question of looking at midwifery-led care in Medicaid populations to support birth equity?
I would. Thank you very much, Dr. Kane Lowe. So I think that as you said, I work a lot with American Association of Birth Centers and with their Government Affairs Committee. I also worked with a recent project that was funded by the Centers for Medicare and Medicaid Innovation called the Strong Start for Mothers and Newborns Initiative. And I think that that project and the data from that are a really good example of how birth center model of care can work with Medicaid beneficiaries. So the goal of this study was to recruit participants who are Medicaid beneficiaries and look at 3 different models of prenatal care, then collect data to determine whether innovative ways of providing prenatal care could actually impact preterm birth and other poor outcomes of pregnancy and birth. And as we all know, as you've learned in this series so far, we do have a lot of disparities in preterm birth and other outcomes that vary across education levels, income levels, and racial and ethnic groups in the US. So at the end of the study, in which we collected data for 3 years, the results were evaluated and analyzed by the Urban Institute. And I think you're going to hear more from that study later on in this series by some of those Urban Institute authors. So I'm just going to touch on a couple of highlights of that. And Kelly, if you would bring up the slide to share that shows just some of these outcomes and in terms of reduction of disparities. So of the 3 models studied, as I said, the birth center model was the one that really showed the significant improved outcomes, including lower preterm birth, low birth weight, lower cesarean rates, and even an average cost savings of over $2,000 for every mother-baby pair. These are Medicaid dollars, and this is savings over the first year of life. So turning to opportunities for growth, if we take those outcomes and look at what we can do to improve access for more Medicaid beneficiaries to the birth center model of care, then I think that we really need to look at better partnering between birth centers and Medicaid, and better partnering with the Medicaid managed care organizations to work to increase access for Medicaid beneficiaries to this model of care. One other thing that I just want to say about the Strong Start study that is not widely known is that the providers in birth centers and birth center providers, as Dr. Kane Lowe mentioned, are CPMs, CNMs, and CMs, and other direct entry licensed midwives, and that was true at the Strong Start project too. So with all midwifery provider types, these outcomes were outstanding. So when we look at opportunities to increase access, one of the biggest challenges for the birth centers, and as Dr. Reese mentioned, we just have birth centers who do not enroll in Medicaid. because the problem of sustainability from reimbursement levels. This varies across states. We have one state that has set facility reimbursement at $400 per birth for everything that's covered in the facility. That's not even enough to pay the nurse that comes in to provide care. So if you look at the average savings in the Strong Start project, and then you look at some of the new efforts to pilot models of value-based reimbursement, I believe that it would be quite possible for the Medicaid managed care organizations to look at opportunities to reimburse better. There are a few small efforts in this direction already, and these are primarily incentive programs being piloted with only a few accredited birth centers. And an example would be an incentive pay for performance payment of $1,000 to $2,000 for each client. And that would mean that there would still be Medicaid dollars saved based on the outcomes. But yet the birth centers could be sustainable enough to actually enroll in Medicaid.
Thank you. Ms. Dale, I would love to hear a health plan perspective on what recommendations do you have for midwifery practices who want to engage with Medicaid health plans? Are there any enablers of success for those looking to build relationships and secure contracts?
Absolutely. So there are 4 recommendations I would offer. The first is to understand the quality metrics, some of which you heard about, that the health plan is evaluated on. We talk about HEDIS affectionately. It's a healthcare effectiveness data and information set. And here for pregnancy, we're looking at things like timeliness of prenatal care so that it happens in the first trimester. We're looking at postpartum care, that the woman has a visit between 21 and 56 days after delivery. The second thing is the importance of partnering to deliver fully integrated care. The way that an MCO is reimbursed by the state or jurisdiction is a per member per month payment. And we're then at risk to take care of all of the needs of the enrollee. And so to do that, we're looking at the whole person. Things work best when our providers are also aligned in looking at the whole person. So for example, at a pregnancy visit, ensuring that there's education about oral health, because we know during pregnancy with the hormonal shift that a woman's gums are more likely to get unhealthy if they don't have the proper care and focus on that. So we would want our midwifery practices to be doing that holistic view as well and making the referrals as appropriate. The second part around this holistic view is looking at both 3 things: social determinants of health, behavioral health, other social needs, and substance use disorders. And my preference would be that at every visit, someone gets screened because things change over time and that the appropriate referrals are made. The fourth thing is around data and tracking of performance. So we saw some of those things looking at the percentage of women that get to full term, the number of NICU admissions or the rate of NICU admissions, and the openness to value-based contracting. And sometimes people think about value-based contracting as a takeaway. I prefer that our providers think about it as an add-on, right? So you're going to get paid for the basics of the service. However, based on the alignment, and I never tell anyone that you must agree to these, we talk about the full slate of things that are possible, and then talk about where are you in terms of your baseline, and what are those things that can be achieved, and how do we evolve in a glide path to continuous improvement. Within this as well, many states have, for the Medicaid managed care organizations, pay for performance measures that are looking at low acuity non-emergency room visits. So that was an unnecessary ER visit, potentially preventable admissions, and all-cause 30-day readmissions. And so understanding those metrics and outcomes and how those are part of what a managed care organization is responsible for, and partnering effectively in order to address the needs of the population really is a great way for us to improve together. And in terms of the enablers, I would give you 2 big ones that enable all those other things to happen. The first is having a robust electronic medical record system because that's a great way to be able to store, analyze, and sort data. And it's also a way to provide information directly to the health plan that helps us to be aligned around care coordination and outcomes. And then second is a relationship with specialists. My preference would be that the midwife or the freestanding birth center has, at a minimum, relationships with endocrinologists, because we do see with the women we serve higher rate of diabetes, hypertension, metabolic syndrome related things, with dentists and behavioral health and substance use disorder providers. So if we match up all of those things, the 4 key factors, and then the 2 enablers, that is a great place for us to start to move along on this journey of success and giving women more of what they need.
Thank you. Dr. Reese, could you walk us through how you supported midwifery-led care and birth equity in Colorado? What are some of the lessons learned, and how do you advise others who are looking to explore this model further?
Sure. First, I want to reiterate that we have been very lucky to have certified nurse midwives as our eligible provider type for many years, and we've always identified and recognized their unique ability and what they bring to the maternity health team to support our Medicaid members. Our nurse midwives are paid at 100% the reimbursement rate for that physicians are paid when they provide the same service. Our nurse midwives do not require any physician oversight or supervision. They have prescription authority, and they also have the ability to be clinical directors or supervisors in multiple healthcare settings, whether it's a clinic that's enrolled as a non-physician practitioner group or in our freestanding birth centers. They are the head honcho. I've been very lucky, and I had the privilege to work in several large hospitals in the OB clinics, and I witnessed the collaborative effort between the clinic physicians and the nurse midwives. And they always recognize the different approaches to maternity care that they each brought to the table. I have been told, however, that that's not consistent everywhere in our state. So I think one of the first lessons learned is to always identify how we can support midwifery practices wherever we can, whether it's to educate, encourage collaborative efforts like was just mentioned about making sure they have access to endocrinologists and other specialties. I think it's also important that we try to improve the access of our members to the provider of choice, whether it's a nurse midwife, the place of choice, whether it's at home, in the hospital, at freestanding birth centers. We still have some work in those areas, as I mentioned, about our rural communities and frontier communities. And I think it's always important to have better communication to make sure we correct any misinformation. For example, Dr. Allman was talking about the payment for freestanding birth centers, and there was a little confusion initially about that. We worked with our freestanding birth centers initially, and we developed a payment method to provide 75% of what the current hospital fee service rate for our freestanding birth centers. Even though they had a lower number of eligible beds, they still get 75% of the facility fee that a hospital would get. In addition, all of the nurse midwives or doctors working in the freestanding birth centers get the same 100% payment for that. As far as advice to explore this model, I think I'm a nerd, I'm a researcher, I love data. So given that, I think it's always appropriate when you're trying to make a change in a Medicaid service to understand any applicable federal laws, guidelines, any state statutes or rules that may support and help you implement that change within the system. Find the correct individual to talk to within that system so they can understand the challenges that you're having. Perhaps find a champion who can move that change forward with upper management. It may take state legislative changes in order for that to occur. It may take federal approval for any implementation change to occur. It might also be important to get external stakeholders to add that voice. But I think above all, dig into the specific details of that state Medicaid agency, understand the process, how they pay different provider types, and understand the process for change.
Thank you. Well, and Ms. Dale, building on what Dr. Reese highlighted in terms of securing the ability for the model of midwife-led care and access to freestanding birth centers to be available, from the health plan perspective, what strategies could you use to engage and inform communities of color about their options regarding midwives and freestanding birth centers?
Sure. Before we inform or engage, it's important to acknowledge and listen. And the acknowledgement is the horrible history we've had in our nation of racism and its multiplier effects that have only been worsened during COVID. And when we skip over that and start with what we think and what we want, I believe we don't engender trust in communities of color. So I'd say the first is for us to all openly acknowledge, despite our best intentions, we have not been demonstrating respectful care. The second piece, which ties to trust as well, is to start with people who are in the community, who are credible messengers. We are not usually the first credible messengers, again, despite all of our good intentions. So doing the hard work to engage with those trusted institutions and individuals helps us to have a much better start. People notice and appreciate when we take that approach that, oh, you didn't just come in and start telling us stuff, right? You went and found people, worked with them, engaged with them. So that's critically important. And then the last piece is really a huge dose of humility. We sometimes do all of our studies and our counting and engaging, and we're not giving people an equal seat at the table. There is a huge amount of value when someone is sitting at the table with all of us, with all our titles and such, right? And they know that their voice is going to be heard, not just at the beginning of the process when we need information. All along the way, we will seek their input and engage. And when we've established that level of credibility and trust and done the hard work, then it is much more fertile ground for all of our work to say, you know, here are some of the options that we have. How do you think we best do this? The front end work is critical, and we often miss that step. And then we are surprised that our outcomes weren't what we wanted, or we didn't get all the warm and fuzzies that people wanted to jump right on board with what we thought was best.
Thank you so much. Critical information that we have to all learn from. Jill, Dr. Allman, I'd like to turn to you for a minute. We've highlighted the role of birth centers, but we haven't really spoken to the role of accreditation for birth centers, which is critical for operations and assurance of quality in Medicaid programs. Could you speak to us a little bit about the why of accreditation is so important?
Certainly, thank you. Kelly, if you would pull up the slide that shows AABC standards and accreditation, that would be helpful. So just quick background overview. American Association of Birth Centers is a professional membership organization for birth centers and other stakeholders and supporters of birth center care. So American Association of Birth Centers establishes the standards for birth centers, which are the basis on which birth centers practice with the highest quality care and with the highest level of safety and following the evidence that is possible. The standards are regularly updated with input from a group of experts to be sure that they are remaining in alignment with the latest evidence. So all birth centers that are members of American Association of Birth Centers agree as part of their membership to provide care using and following these birth center standards. So I will say that some birth centers may decide that while they endorse and follow all the AABC standards for quality and safety, they may feel that they cannot afford accreditation due to their small volume or the cost of accreditation. So it becomes a complicated issue, even though accreditation is the mark of the highest, the commitment to the highest quality of care being provided in the birth centers. There are still some equity issues where some birth centers may, especially if they're providing care to a solely Medicaid population, which means lower reimbursement, they may not feel that they can afford accreditation. So this becomes a problem. But I just wanted to say that the Commission for Accreditation of Birth Centers is the sister organization that's responsible for the actual accreditation process of birth centers. And it is a rigorous program that includes site visits, a review of all policies, and a medical records review every 3 years with intermittent annual updates. And in addition, accredited birth centers must enter all of their data about their care and their births into a database such as the Perinatal Data Registry, which is a validated data system. So there are a few states that require CABC accreditation for licensure, such as in the state of Minnesota and Montana. If a birth center is accredited, then they are deemed licensed in those states. And I see that as an opportunity that should be looked at, because if birth centers don't have the dual cost associated with licensure and accreditation, that can be challenging for some birth centers to meet. There are also a few states that require accreditation because they don't currently have birth center licensure or regulation. So examples are Louisiana and North Carolina. They recognize accredited birth centers as eligible for Medicaid reimbursement. That's in their Medicaid regulation. So as you can see, it's a varied picture across states. There are a growing number of Medicaid managed care organizations and state Medicaids that are requiring accreditation before they will credential birth centers to be in network. So we do see that trend. We know that is the desired end, but we also know in terms of providing equity and access, it can be challenging and due to cost. So that is a challenge that needs a solution.
Thank you. And I appreciate each of the comments and responses to the different questions. As we get ready to transition to our open Q&A, I'd just like to follow up on something you indicated, Ms. Dale, when you referenced the impact of COVID. I wonder if you could just speak to the opportunities in this very challenging space of the impact of COVID on pregnant individuals. Could we hear some thoughts or advice you might have for folks to consider when trying to improve access to safe care for pregnant Medicaid enrollees during this pandemic?
Sure. The first is collaboration. I am so pleased that in the district, and albeit we're much smaller than a Colorado, right? Is that we had a cross collaboration group of individuals that were meeting that went across hospitals, federally qualified health centers, individual providers, all the Medicaid managed care organizations. Several of our council members were involved, and several government entities. Why was that important? It was a level of communication that was unprecedented in our city, right? Having all those stakeholders involved and engaged, we had a very rapid exchange of information, ideas, and generative thinking to focus on solutions and messaging to those we intended to serve. So don't underscore the importance of collaboration. Reaching out and being engaged together all at the same time really helped us to understand at a very detailed level often what was happening to women in the care experience or as they aimed to access care. Or what we learned was how women were making very different decisions, being concerned about accessing care and getting infected, right? So how did we need to message differently? How did the hospitals need to leverage a different level of flexibility about how many attendants could be there or for how long, right? So all of that conversation and collaboration was incredibly useful. The second thing is around data. When we have enough data, and this is where the health plans can play a very important role, is we often have not only past history and clinical information in a very detailed way. A woman might have gone to the emergency room, but she's not yet come back for another appointment, so you may not know that. So that importance of information exchange from a data perspective helps us to pinpoint where there's more risk, less risk, and we can change and target our efforts more specifically to what is occurring over time versus only some components of the system knowing things and another component not knowing, right? I always believe in democratizing data so that we give information to those who are at the level of service so they can make the best possible decisions. The third thing, and my final thing, is around paying more attention to social determinants of health. Many studies have shown over time that domestic violence and many other things that occur in someone's, pregnant woman's life before she got pregnant, right, can be exacerbated during pregnancy. And when we're not paying attention and taking the time to find those things out and ensure that the woman gets connected to resources, then we are more challenged. And so that importance of collecting information, I recognize, for all the reasons that we've just talked about, that all of the work to address social risk factors cannot rest on the provider. And that's a great space in which MCOs can invest and be that entity to whom that warm connection is made, so that better things happen, right? So we, for example, have done meal delivery. We've done more meal delivery during COVID, so that people who needed to quarantine, pregnant women who needed to quarantine, didn't need to worry about leaving. When we provide meals, we're providing it for the woman and everyone in the household, because no mom is going to have her kids starving when she has food, right? We did home delivered medications. We ramped up our efforts there so that it was touchless delivery. Provided masks, because many times when women had to go for an appointment, they may not have had a mask. So we made sure they had mask and sanitizer, and that we upped our transportation, rolling that in terms of making sure that it was as safe as possible and as effective and timely as possible. So thinking about all those things, when we use that broadest lens of the whole person within the context of the environments where they live and what are likely challenges, we do a lot better to provide the best level of service. And then if we do that across the system to share information with us each doing our part, wonderful things happen. And I'm just always pleased when that level of collaboration and engagement occurs so that our women are best served.
Thank you so much. And I know all of the other two panelists have thoughts and responses to thinking about improvement of care and safety related to COVID, but I think we're going to transition to our open Q&A. One thing I will highlight, though, is that the opportunity to access birth centers has been seen as a critical opportunity during the pandemic in terms of having a new space. And it's not a new space, but it's a space many didn't think of before when they thought of traditional patterns of just assuming hospital-based care. So that was another big opportunity for people to look at realignment of services and safety when we were thinking about risk concerns related to hospitals. As we turn to our Q&A from our community that's been listening to us today, Preeti, you have been monitoring the Q&A. Do you think you could offer us the first question?
Yeah, absolutely. We'll start with Dr. Reese, and also Dr. Gale could chime in with this question. Someone asked about the difficulties of how to determine network adequacy. Could you discuss opportunities to increase access to midwifery-led care by establishing network adequacy standards?
You know, that's a very challenging question. All of our providers are paid fee for service, so we don't necessarily contract with them specifically. They choose whether they want to enroll in the Medicaid program, and they choose exactly where they want to open their practices. So as I mentioned before, I think it's really critical that we try to identify methods to help nurse midwives and our freestanding birth centers identify challenges that they might have more in the rural communities, and to help them be able to identify how they can collaborate with larger organizations to support their service provision. So there's not a quick answer to that. That's just a huge challenge. And we identified some of those lack of provider types by looking at our claim system. That's our main data source and where these unique providers are located. So I can't give a specific answer for that. It is a challenge, and we do hope to be able to work on that to increase.
Great, thank you for that. Dr. Allman, other than the accreditation fee, what are some of the other costs that a freestanding birth center might experience in the process of gaining accreditation? And could these expenses lead to better outcomes and higher reimbursement?
Thank you for that question. And I just wanted to comment briefly, very briefly, on the previous question. by saying that one of the ways to increase access to midwifery models, midwifery practices, and birth centers is that all provider directories need to add some new headings. The new headings should be freestanding birth centers and midwives, because those don't show up in the provider directories or in the service directories that are given to consumers, so they can't find those services. So that's just one plug that I wanted to throw in there. So as far as cost, due to accreditation, one thing that I forgot to mention is that the American Association of Birth Centers Foundation actually provides accreditation scholarships, where they will pay half of the upfront costs if birth centers who are seeking accreditation apply for those scholarships. The main costs are really just associated with time in making sure that all policies and procedures are in alignment with the AAB, the birth center standards, and the indicators that the accreditation, the CABC has developed for meeting those standards. So it's really just a process of time. And it's possible that birth centers may not previously have been entering their data into a prospective data collection system. So that will definitely take more staff time in involvement. But other than that, I can't think of any other cost as far as providing services that birth centers are not already providing.
And Dr. Allman, as a quick follow-up, are there any opportunities for state Medicaid agencies to support birth centers in their accreditation process?
That's a great question. And, you know, I mentioned that some states actually will recognize accreditation as meeting the requirements for licensure. So that's not really a direct way that state Medicaid agencies can support accreditation. But I think that the trends toward requiring accreditation for credentialing are leading to more birth centers becoming accredited. That seems to be the trend. And not only Medicaid agencies, but more and more commercial payers are requiring that too. So I think that over time, we're going to have more and more accredited birth centers. So, you know, thinking creatively, if state Medicaid and MCOs would like to support more birth centers to become accredited, they could either give them a grant or an incentive payment to become accredited. That would certainly be helpful in the process.
Great, thank you so much. And I just want to give Ms. Dale, if you want to add any last comments or a comment on the network adequacy question, welcome that before we wrap up.
Absolutely. So on the network adequacy, one way we could start is by looking at where most of the births or the women who are pregnant are, and ensuring that accessibility means that they can get what they need in the neighborhood where they live, right? Sometimes, at least in the district, as small as we are, women are traveling because we don't have a lot of midwives and a lot of birth centers to get the care they need, which sometimes just the time factor, even though we have transportation as a benefit, creates a challenge. So I'd say if we did a heat map that said, here's where our women historically, look at 3 years worth of data, have been pregnant, and ensure that we do some cluster analysis and say, these are the places where we need to have, you know, midwives and freestanding birth centers. That would be a great start to making sure that there's a level of adequacy so that women aren't going so far to get the service that they desire.
Great, thank you so much, Ms. Dale, and to all the panelists for your responses. I'll turn it over to Chloe, or actually Dr. Kane Lowe, for your last words.
I just know that Chloe will address, there's a number of excellent questions we couldn't get to at this time, but that we'll have a chance to follow up with and make sure they're distributed to everyone. I've tried to answer a few as we've been going along. And I just really appreciate this esteemed panel for everything you've contributed today. So thank you.
Thanks for having us.
Thank
Chloe?
you very much.
All right. At this time, everyone should have received an email with the link to complete today's brief session evaluation. I also dropped a link into the chat. We know that you have opinions and suggestions, and we want to hear them. So if you did not receive the email with the session evaluation, please contact me. My email is on the slide. Our next session is scheduled for January 8th and will be focused on launching and operating Medicaid-focused midwifery-led models of care. Keep an eye out for the pre-session email with the agenda and pre-session required activities. If you haven't already, please remember to add Jennifer Moores to your email contact list to ensure that the series emails are not sent to your spam box. Her email is also posted on the slide. We want to thank you all for your participation, and we look forward to seeing you at the January session.
Thank you, everyone. Stay safe.
Thank you.